Thanks, Michelle. What a personal and professional treat it is to introduce one's mentees and friends throughout this meeting. Our conference kicks off with Dr. Alex Kim's talk, The Process of Making a Genetic Diagnosis, a cornerstone of NIMAC's goals to share genetic expertise and increase access to services. Alex will give examples of how family history, physical exam, genetic testing, and thoughtful communication contribute to empowering patients and families. Alex is the current Medical Biochemical Genetics Fellow at Johns Hopkins Hospital. He completed training in both pediatric and medical genetics, the latter of which included an extended chief residency. He will join the faculty at Johns Hopkins All Children's Hospital to build a new metabolic genetics program starting in July. So with that, Alex, we welcome the talk.
All right, good morning, everybody. Can you see my slides and can you hear me? All right, yes. I'm seeing some nods, so we'll sort of launch right into things. If you have any questions at any time, please feel free to type them in the chat. I'll try to keep an eye on it, monitor, answer questions as we can go along. And if not, I'll try to revisit at the end. And then I think, later on, there'll be avenues to get in touch if you have any further questions. So with that, we will get started. So this is our disclosure statement. Neither I nor Dr. Berdurtha have any relevant financial interests or arrangements in any amount within the past 12 months with one or more organizations, which could be perceived as a real or apparent conflict of interest, and which would reasonably appear to influence my role as a potential faculty/committee member for any continuing medical education activity. We prepared this presentation independently. And last but not least, we intend to reference unlabeled/investigational use of drugs, specifically angiotensin receptor blockers, mitapivat, and Millicent in our presentation. And that's sort of a hint to say that genetics as a field is starting to shift. Now, before we sort of launch into things, I thought we would get started with a fun interactive activity. So there's this nice tool called Mentimeter, which I believe many other presenters will use. And if you take a look in the chat, what you'll find in a moment is a link to click on it, and we'll sort of generate a word cloud. So what I'd like to do is sort of see what you all think about, what is the meaning of making or receiving a genetic diagnosis to you? Do you have any experience with this? What are things that come to your mind? What are sort of concerns, questions you have? So if you sort of click on that link, you can sort of see things populate in real time, which is a really cool thing. So we see relief, certainty, hope, clarity. Clarity is a big one, it looks like. Management, uncertainty, and a journey, certainly. So this is sort of one of the cool things we can do in the modern age. And although we're all sort of meeting virtually, we can sort of see that we have a diversity of viewpoints. Key themes, it looks like, is answers, relief, management, clarity, and hope. Thank you all for participating, and feel free if you want to keep on sort of putting these in, and then maybe I can pull it up again in a little while. With that, let's launch into things. So why are we all here? Well, in some sense, I'm sort of preaching to the choir because you're all sort of probably either experienced this or you're aware of this. When it comes to a genetic condition, even though each condition is individually rare, our mantra is sort of that as a collective, it's actually quite common. These are things that lots of families will actually be impacted by. And I think that overall, quite underestimated. And then what ends up happening if you have underlying genetic diagnosis, but you're not able to get a genetic diagnosis, that process can take a very long time, months, years even. Well, there are many consequences. One, you can never have a diagnosis, and that can be associated with a lot of uncertainty. You can be misdiagnosed one or more times. You end up having to see too many doctors, getting too many tests. In some cases, you can actually pass away prematurely. You can have affected family members. There are many consequences to this. So how do we prevent this? Well, you could think to yourself, well, why don't we just have more medical geneticists and genetic counselors and genetic assistants, and I'll build up that team? Well, every couple of years, you're going to see an article just like this saying that everybody's maxed out in their practices, very limited capacity, and those on the sort of patient and family side of things will have experienced a long wait time, sometimes have to drive very long distances, which is why a session like this is great, because then we'll talk about, well, how do we expand access to genetic services? Now, what do? We still try, right? So there are clinical reports to sort of guide the care of people with certain conditions that are common enough. So one that pediatricians may be well acquainted with is the one for Down syndrome, the care of people with Down syndrome. And actually, I just want to call your attention to a new a new one for the care of people with achondroplasia. And last but not least, I'd be remiss if I didn't talk about newborn screening. And for example, if you don't have access to a metabolic geneticist and you have an abnormal newborn screen, you don't know what to do with it. Well, there's these act sheets and algorithms that can tell you, one, what do you need to think about? Two, how worried do you need to be? And how can you work it up? But I want to go through the process of making a genetic diagnosis, try to demystify that, make the complex or seemingly complex simple, and sort of have that be a natural launching point to many of the other talks for today and tomorrow. Well, this all sort of started as primarily a diagnostic subspecialty, and it sought to understand the variation of physical features that were observed in people. And at that time, it was both an art and a science. Now, one important distinction made earlier on by Dr. David Smith was that we don't want to presume that there was an environmental cause, that there was a so-called teratogenic exposure that changed things. Now, of course, the field as a whole has evolved since then. It informs genetic test selection and interpretation. It has implications for clinical care, as came up in the word cloud, including some treatments now. And last but not least, it seeks to understand the variation of physical features. So that part hasn't gone away, and also hasn't gone away that it remains both an art and a science. There's some deliberate practice involved. Now, for example, if you're faced with a child or an individual with this ear, well, would you be able to describe that? That's one question to think to yourself. Can you even describe your own ear? And why or why not? Well, what I would propose is that it's important to know what's typical in order to sort of be able to describe what's atypical. And, you know, if some of this is dependent on the family context, the ancestral context, and, you know, simply describing an ear as atypical doesn't necessarily point you in the right direction when it comes to a genetic diagnosis. And that's because atypical, quote unquote, can mean many different things. It can mean that the ear is slightly squared off, or is it completely missing? Now, a big part of medicine, both from medical team to medical team and medical team to patient and family, is communication. And we all need to be sort of speaking the same language in order to be able to communicate effectively. So fortunately, we have standardized nomenclature for those purposes. It's free of charge, developed by a panel of world experts, divided by sort of body region, including the ears, the nose and philtrum, the eyes, the overall head. One thing I really like about this is sort of it lays out what you would typically expect, so that even if you didn't know the fancy genetic name for a specific type of difference in the ear, you can say, well, this is the anatomy I expect, and what I'm seeing looks different. So, you know, this could be considered an example of a quote unquote classic charge ear. There are various configurations that are slightly different. For example, discontinuous antihelix and antitragus. But long story short, why do we even look at ears in the first place? Well, it's to get us to an answer. So if you saw this type of ear and you're suspecting the possibility of CHARGE syndrome, you could say that, well, I'm concerned about this. Let's order genetic testing for that and go for the gene. And the likelihood that your genetic testing will be find the answer is sort of dependent on the whole picture, not just one finding or another finding, but it's sort of the whole process. And it's sort of a very dynamic and stepwise process, genetic evaluations. Now, really, the cornerstone, the foundation of a genetic evaluation and the process of making a genetic diagnosis is the family history. It establishes your understanding of the baseline probability of specific types of diagnoses as an explanation for what's going on. And I would say that a family history is always useful. Of course, I'm biased, but I think that a positive family history really sort of allows you to narrow the list of things you need to think about. But if there's a quote unquote negative family history, no obvious pattern, well, that's also helpful too, because there are certain conditions where you actually expect to see an obvious pattern. So the fact that you don't changes the probabilities. So I think that it's great for everybody to have a good sense of their family history. Now, what's considered a quote unquote positive family history? Well, you can sort of memorize the classic inheritance patterns, or you can sort of have this more practical rule of 2 or 2, or find other ways to think about it. So I really like this. It's very practical, and you have 2 or more affected family members. That sort of things makes you think, could this be a genetic inherited cause? 2 or more affected generations. Maybe one person has too many clinical findings, too many things going on. Or maybe there's something that has happened too early. So maybe not necessarily unexpected broadly, but unexpected in children versus adults. And of course, there are classic patterns, autosomal dominant, sort of running from generation to generation, so to speak, a quote unquote vertical pattern. You can have what we call an autosomal recessive pattern, where it may be sort of having genetic risk factors and carriers sort of along the way, but it's only until a single generation that things are unmasked, so to speak. You can have X-linked clinical recessive, where you have predominantly males affected. And then you have some more, you can get increasingly complex, including the so-called mitochondrial matrilineal inheritance pattern, where you can have both males and females affected by a condition, but it's always sort of passed through the mothers. And an important thing to note is, even though you would presume that everybody with the same genetic condition has the same thing, well, as we know, that's not always the case. Now, the family history, as we learn more about these conditions, our understanding of the family history and its role changes. So for example, this is Alagille syndrome. It's one of the big things we think about with what we call cholestatic liver disease in children, infants. And when this was first described, it was thought that all of these cases happened for the first time, so that there was expected to be a negative family history. But as it turns out, well, maybe the negative family history isn't actually negative. And in fact, what they're trying to show here is that you have a son and a father, both of whom have Alagille, and then you have a daughter and a father, both of whom have Alagille, and then perhaps you could convince yourself that they, even though you would expect a child to have elements of their mother and father in terms of their physical features, there's a specific look to the eyes and the nose, for example, and the overall sort of shape of the face. But if you have this family history, you have this clinical concern for Alagille, you can get testing, make a diagnosis, and actually impact the management. There are certain things you would want to do or not want to do if you knew that this is going on. As an example of the power of the family history, say, for example, you have a child who's born and has lip freckles, and as far as you can tell, nothing else. But you know that they have a first-degree relative with Peutz-Jeghers syndrome. Well, then you have the diagnosis of Peutz-Jeghers syndrome, and based on that, you can monitor for very important sort of later onset potential complications, and some of which can actually be life-threatening. So having this knowledge can really sort of inform how you take care of these patients and sort of best steward their health and overall well-being. Now, once you have the family history, then you want to think about all the clinical findings within context. It's nice to think about them as either being significant or specific, both or neither. So for example, if you have this something called the molar tooth sign, that's significant because it refers to a difference in the way sort of the brainstem is developed and formed, but it's also fairly specific because if you see this, not only is it important for the sort of way the brainstem is formed, but you know that you can think about something called Joubert syndrome or related disorders. So it really sort of points you in a very specific direction. Whereas, for example, fifth finger clinodactyly, which is a very fancy way of saying that your pinky is sort of curved in a little bit, you can take a look at your hand right now and sort of see, do you have it or not? It doesn't really necessarily mean anything. And just because your finger is a little bit curved doesn't mean you have any difficulties with your dexterity using your hands. Now, no, don't worry about all the numbers, but basically knowing more about your patient or yourself can definitely change the probability of certain genetic conditions. For example, there's this 22q11.2 deletion syndrome. Yes, that's a mouthful, but has a baseline probability just in the general population, if you don't know anything about, 1 in 6,000. But if you know if they have a certain type of heart change called tetralogy flow, that probability jumps up to 7.554%. So if you understand your patient, understand yourself, your probability of a certain type of genetic condition changes significantly. You want to be objective, if at all possible. So you want to measure things, weight, length, head circumference. You can do basic things like counting. We can all do that. And also you want to sort of localize, is there something on the left that should be on the right or vice versa? One big point I want to say is that the facial gestalt is not diagnostic. So when you look back at the sort of old, original descriptions for a lot of conditions like Down syndrome or Smith-Magenis syndrome or Kleefstra syndrome or the Zellweger spectrum disorders, you may sort of see that there's a quote unquote characteristic facies described. One thing to note, though, is that a lot of these are described in sort of European populations, which doesn't necessarily translate to populations from different regions of the world, one. And two, if you were to sort of read the description just in text of the facial features, for example, upslanting palpebral fissures, there'd be a lot of overlap, and you wouldn't be able to say that it's one versus the other versus the other. So it's just to be mindful of the fact that, just because you're sort of recognizing or not recognizing a certain sort of pattern of facial features, it doesn't necessarily point you towards one diagnosis, or the absence of that pattern doesn't necessarily exclude that. And of course, I just talked about how, not seeing a pattern doesn't necessarily exclude things, but ultimately what it comes down to is trying to put together clinical findings in a pattern. And for example, if you found somebody with a coloboma, change of the eye, change in the heart, changes sort of the back of the nose, so to speak, difficulties of growth, and changes in sort of the genitourinary tract and the ears, then you can sort of say, well, I have my pattern in my mind. Could this be CHARD syndrome? Now, when you're sort of trying to figure out what's going on, sometimes the genetic condition in question is common enough and has enough experts in to have what we call a clinical diagnostic criteria formally. So for example, if you have a family member or a patient with difficulties of growth, differences in development, then you can sort of think to yourself, well, could this be Cornelia de Lange syndrome? And the very nice thing is that now there are enough patients and enough is known to say, well, these are the diagnostic criteria. If they meet, then this is the specific panel of genes that you want to test for. Sometimes there's not enough patients for formal clinical diagnostic criteria, but there are enough experts to say, well, this is what we see in the patients, different percentages, and more importantly, well, these are things you can do. What do you expect? So this is an example of a gene reviews. These are sort of written by sort of experts who are go through and talk about how to make the diagnosis, what are the characteristics, how do you manage, how do you do genetic counseling around these conditions, and what are sort of resources for families, whether it's patient support groups or what have you. And the really nice thing I like is it tells you when it was last updated, one, and two, how long they think it's going to take you to read this. So this gene reviews for CHARD syndrome takes you around 29 minutes on average to read through from start to finish. And in some rare cases, you can actually have a sort of a nice systemic calculator for clinical findings to say, hey, we're concerned for the possibility of something like Marfan syndrome, which is a connective tissue condition, can be related to changes in sort of the way the skeletons form, as well as the big blood vessels. And you can actually click through and say, oh, we see this, we see this, we see this. Say, for example, you see this word protrusio acetabulae, and you're like, what is that? I've never heard of that in my life. Well, you can click on this little arrow, and it'll actually tell you what it is. To my knowledge, these are sort of few and far between, but we certainly cherish the resources as they're available. And in some cases, you can actually have enough known about the gene and changes in a gene that you can calculate the probability you're going to get an answer if you test the gene. So this is for a gene called PTEN associated with different things like larger head size, as well as hereditary predisposition to developing certain types of cancers. And depending on the clinical features, you can actually calculate what is the likelihood we're going to make a diagnosis if we send testing for this gene. Now, you never want to have a list that's only one thing. So you want to have a sort of a broad list of different genetic conditions to consider, because just because it's not the first thing doesn't mean it couldn't be the second thing. And you want to focus on the most significant and specific clinical findings and sort of probability weight that, depending on your understanding of what's going on. And one important point is that the differential diagnosis, the list of conditions to think about, should be allowed to evolve if the clinical picture changes. If with time we're noticing new things or things don't change as we would expect them, that should be taken into account. And in some sense, you want to focus on the most likely diagnoses, because you want to sort of make sure that we're trying to focus on making that diagnosis. But at the same time, I think it's also useful to have what we call can't miss diagnoses, things that may not be the most likely necessarily, but would have very specific actionability to it. So for example, if you have a newborn or an infant with seizures, there are many different forms of early infantile epileptic encephalopathy. As of the time I put this slide together, there was at least 80. But you don't want to miss antiquin deficiency, which is sort of the short way of saying this, because you can treat that with vitamin B6, the B6 responsive epilepsy. So while this is quite a bit rare, you don't want to miss that, because they're very specific and, in the grand scheme of things, relatively straightforward way to sort of go about things. Now, when you have that list of conditions, you also want to think about the type of genetic change that could be associated with these conditions, because there isn't a one-size-fits-all genetic test, at least not in this day and age. So the type of genetic test is tailored towards the type of genetic change, which is tailored based on the type of genetic condition you're considering. So to start sort of big and to go small, you can have extra missing chromosomes. The most common example is Down syndrome, which one cause could be an entire extra chromosome 21. There are clues in sort of the medical history. For example, I'm not saying that you're truly advanced in age if you're 35 at the time of giving birth, but just from a medical perspective, they just defined advanced maternal age as 35 or older at the time of birth. And if you think about aneuploidies, extra or missing chromosomes, you want to get a karyotype, look at the chromosomes. You can actually have rearrangements of chromosomes. And this can also be another cause of Down syndrome. So there's different types of Down syndrome. There are clues to think about. For example, a story of multiple pregnancy losses could make you think, could there be a rearrangement? And then there's certain changes in genetic testing in offspring that can make you think about the possibility of a rearrangement. And you want to look at the chromosomes. Now, then you can have extra missing pieces of chromosomes. And I'd say that sort of overall, this is sort of where you sort of your mind naturally goes to based on probabilities, unless something about the patient or your family member makes you think differently. So there are many examples of this. Some big clues are, with developmental delay, autism spectrum disorder, multiple anomalies, you really think about, well, could there be something to this? You want to look for extra missing pieces of chromosomes, and there's a specific test for that. You can have changes in specific genes, so getting down even smaller. Many different examples, and this is really based on sort of family history in terms of any patterns or clinical findings in a very specific pattern. And again, if you're thinking about a change in a gene, you want to test that gene or sort of panel thereof. You can actually have changes in the way that genes are interpreted by the genetic machinery, and you want to do specific testing for that, something called methylation. There's some clues, again, the use of assisted reproductive technologies and or the underlying subfertility that required it. Then you can have changes in what we call the mitochondrial genome. I wouldn't worry too much about the details, only to say that you have your own DNA, quote unquote nuclear DNA, and you have this mitochondrial DNA. In many examples, there are some clues that matrilineal inheritance pattern alluded to earlier. And again, if you think it's a mitochondrial genomic change, you want to test the mitochondrial genome. And then there are non-genetic etiologies, including sort of a throwback to sort of the old thinking about environmental exposure, teratogens, diabetes. Zika virus was recently sort of in the public eye. And you also want to think that maybe things could be a little bit more complicated. You can use OMIM as a way to sort of think about the list of things to consider. There's other resources behind paywalls. There's Face2Gene, which is actually a phone app that can actually sort of scan and use machine learning and neural network to sort of figure out probabilities based on clinical findings and actually pictures. And then there's literature review. What have people seen? What have they described? And ultimately, if you think there's a genetic change, you want to sort of obtain consent and order testing. And obtain a consent is a really important point because informed consent is a process, and it also implies that genetic testing is not mandatory. Just because you think that there's a high chance of getting an answer from genetic testing doesn't necessarily mean the patient and family are in a spot where they want that information necessarily or can receive that. So you want to make sure that they want it. And again, you want to make sure the testing hasn't already been done. And the thing to think about is a negative genetic test doesn't mean it's not a genetic diagnosis. And a few clinical pearls. I think this is a really key point. You want to be careful with your word choice. You really never know if a positive test result is good news or bad news, or a negative test result, whether it's bad news or good news. And you also want to think about the fact that patients and their families may not consider themselves to have a disorder or be defined by it. So there's a difference between deaf with a lowercase d versus deaf, the community with a capital D. And then, for example, when it comes to people with achondroplasia, which is sort of one of the most common forms of what we call a dwarfism, you want to use their given names or use the agreed upon terms like little people, dwarfs, rather than the M word, so to speak. You want to avoid the stigmatizing language. And actually, a sort of a safe rule is to use the words that your patients and families do. And also to use silence for longer than you feel comfortable. And I'd actually argue there's no way to use too much silence. Now, there's actually some legal precedent to sort of avoiding certain stigmatizing terminology. We now use the term intellectual disability rather than the antiquated term. And the few last pearls, you want to make sure you congratulate new parents, except under extraordinary circumstances. If there's uncertainty, whether about a diagnosis of biological sex, don't try to sort of put certainty where it doesn't necessarily belong quite yet. You don't want to be too negative, but at the same time, you don't want to be too positive. So there's an element of balance here. And you also want to see sort of how is information best received? Is the person you're in front of you, is the family member, is the patient sort of a big picture person where they focus on small details? And it's important to note that if you have a baby maybe mom is one and dad is another. And another important thing is that just because somebody is a big picture person right now doesn't mean they're going to stay a big picture person later on. Maybe at some point they will find themselves in need of details. So you want to sort of adapt, and you also want to build trust with honesty. And there are many different frameworks for communicating. I really like this one, SPIKES. It comes out of the oncology literature. And in the last 2 minutes, I'm going to briefly go through some cases, which is sort of a composite from sort of real life lessons learned, and then we'll launch into breakout groups. So say, for example, we have a 7-year-old male admitted for pneumonia, but then mother asks, I've always noticed that he has this penile freckling, which I'm not sort of, is that typical? Do we see this in the general population? And the family history, perhaps you see large head size, certain types of cancers, and then you measure his head and it's like, well, this actually is sort of on the larger side. You identify a pattern, you look at OMIM, and really you think, could this be Cowden syndrome? A change in P10, you order testing, make a diagnosis, which affects not only the patient, but the entire family, including specific screening for certain types of cancers. And actually you can sort of make a big difference, not just for one person, but a whole group of people. And again, fortunately in this case, we have gene reviews, which sort of lays out the diagnosis and management, including for pediatric and adult onset cancer risks. So you want to check the thyroid, check the breast. You want to make sure that there's colonoscopies as well. How about this? 2-week-old female, everything's fine. Notice that the eyes seem to be a little bit further apart, and there's a bifid uvula, a double uvula here. And that's not something that was seen in the child's parents. Nothing in the family history. Both of these things can appear in isolation in the general population. Is this genetic? Is it a simple coincidence? And if you plug it into something like OMIM, what you'll find is there are a very long list of things to think about, but there are a few common elements, including the fact that you can have increase in the size of the aorta, which is the largest sort of blood vessel in the body. And so like, okay, I can't narrow it down, but I know I don't want to miss an enlarged aorta. So you get an echocardiogram, and let's say this is definitely somebody who needs to see genetics. Send a panel, given that the list of things to think about is very large. You can make a diagnosis, and actually in this day and age begin specific treatment. So angiotensin receptor blockers actually used to stabilize the aortic diameter. And there are guidelines, primers for management as well. Cardiovascular care, what to do in pregnancy now that these patients are living to that age. And last but not least, future directions. We're thinking about treatments. You can have small molecules for things like anemia. And you can even have as custom tailored as specific to a person's individual genetic change and having a custom tailored treatment for them. And granted, something like this will take a lot of time and infrastructure, but we could get to the point that one day, not only will sort of management be based on the individual's diagnosis, but the particular genetic change underlying the diagnosis. And with that, what I'd like to do is launch into breakout rooms. We'll spend around 7 to 8 minutes in the breakout rooms. And what I'd like you to sort of think about is, do you have experience with making a diagnosis or receiving a genetic diagnosis? Did what you just hear make sense? Were there key differences? And how can we sort of improve the process for everybody? And thank you for listening. And we'll regroup at the end.
Thanks, Alex. So Alex, I think you've got 30 seconds here. Do you want to comment on what you saw? And then I'm going to turn it back to Michelle. Alex and I will be available by email and throughout the time. He has some other things also, so it may not be immediate, but we're happy to take questions. You want to comment on anything, Alex, before we turn this back to Michelle and Wendy?
I guess as a final statement, what I can say in terms of the final word cloud is that some of the biggest themes are answers, clarity, understanding, hope, relief. There's a lot of acknowledgement of the fact that a lot of this can be a process. There's a lot of uncertainty. And if there's one thing that you take away from all this is that the family history is key. And you want to understand the person in front of you, both in terms of how to think about making that diagnosis, but sort of just as importantly, or even more importantly, how to communicate with them. So I'd like to thank you all for your time and hope you have a great rest of the conference.